Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy counselor, and I'm joined today, as always, with Dr. Jason Martin, board-certified plastic and reconstructive surgeon. Emphasis today on the reconstruction. How are you doing, Dr. Martin?
Very, very good. We have a great topic today.
We do, but before we get into it, I have something I want to talk about.
Sure.
So I know we're not supposed to talk about time frames or when we're recording this, or, there is no wall here. But today is International Women's Day.
Yep.
And
which is one of the reasons why we chose this topic.
It's a great topic, and something that I'm very passionate about is women's empowerment, not in like what were the suffragettes, not in that kind of way, but more in just that we've been doing this for a long time. You and I have been working together for 11 years, and on the daily basis, we have women in our office who are here for a reason, varied as that may be, but it's very often because they are very unhappy with something about themselves. And, that's fine. Like, we are all about change and positivity and transformation.
That's the tenets of this podcast.
It is.
Education, transformation.
And empowerment.
Empowerment, yeah.
And we really do believe it. But occasionally a woman comes in our office that has placed so much of her own self-worth on her outward appearance in a way that has just impacted her life for years.
Negatively, yeah.
Negatively, and those conversations, I always just want to reach into that woman's heart and grab it and tell them that they are amazing and beautiful and so much more than the thing about them that they dislike. And it's so hard because we want to help these women feel better about themselves. But in the same time, there's those women, we could do all the surgery in the world and it's never going to be enough because they can't reach a place of acceptance of their own body and of loving themselves. And
that's hard to watch.
It's so hard.
For our office, we do cosmetic surgery, but we also do reconstructive surgery, and we deal with the same issue with all of our patients, primarily female. It's very hard to watch. We have an episode of this podcast on self-perception, and it shows how difficult it is to even understand from a scientific standpoint.
Yeah. And bringing it back around to what we're talking about today, when I very first started working for you, long time ago, there was a young patient who had breast cancer and who was in her 20s.
I remember her.
And I was so devastated to understand that a woman in their 20s could get breast cancer and have to have a double mastectomy and a breast reconstruction. And it kind of made me take a moment and think about my own breasts and think oh my gosh, I have these 2 ticking time bombs on my chest.
Right.
But at the same time, in that same moment, I kind of then had this epiphany is not the right word, but this thought process of, well, if that's the case, then you know what? I need to accept and love my breasts for what they are in this moment because they could be gone at any time. Right. And that is so hard. And I think, with these women that we see for breast reconstruction, there is no great option for breast reconstruction. We will talk about the best ones, and you do amazing reconstructive surgery. And these women look as good as they can possibly look after this. But it's still a horrific thing, and it's barbaric surgery, and it's not what anyone wants for themselves.
No.
So,
and the hardest part about breast cancer or any cancer is that you didn't choose it, right? There was really nothing you can think of that made you have this problem.
Right.
If you feel like you're the unlucky one, and your heart goes out for these patients and for people struggling with this. And then especially related to your breasts, which defines your femininity, defines you as a woman, it's a emotional process to go through besides just saying, I'm going to survive this. I'm going to be strong. I'm going to make it through this. And that's the beauty of plastic surgery and reconstructive surgery, right? Is that we try in our small ways, albeit not perfect, is to give people a sense of normality and to make them feel whole again. And that's true in cosmetic surgery too, but definitely true in reconstructive surgery. And it's, like you're saying, it's not perfect, but it gives them a sense of closure. That you can move on. And hopefully that's what you get from this episode today. If you're struggling with breast cancer, you have a family member or you know someone and you're just trying to understand reconstruction, breast reconstruction, we're going to give you all the information to empower you, to educate you, so you can go through this process, make the smart decisions, and then close the door and move on to a life that is about survival and a life that is about beating cancer. So, but I do remember that patient. Yeah. I have to be honest with you because I was right when I was starting out.
Yep.
I was young too.
Yes, we were all young.
Yeah, we're not young anymore.
No, we're not, but we were.
Things have changed.
They have. But what has not changed is for all the women out there listening to this, you are incredible and amazing, and who you are has nothing to do with the body that you're in, and just embrace that. It's natural. It's International Women's Day.
Right.
Girl power.
And that's true even if you have to go through a mastectomy, it doesn't define you,
Yep.
right? So we're going to talk today about recreating things that God or nature created. But that's not ultimately what is self-perception is about. Self-perception is about you and your life and the arc of your life and where you feel like you fit into the world. So, but we're going to talk about the nitty-gritty here. I think it's important, right?
It is.
Yeah.
Mm-hmm.
Details, details, details. The hardest part when you get rocked, when your world is rocked, is to get information and keep it in your head, right?
Oh, absolutely. And a lot of women are so uneducated. They're very frequently given one option for reconstruction by their surgeon.
Which is exactly why we're doing this podcast today. Mm-hmm. That we're going to talk about everything. Some of the things I don't even really do in my practice. We're going to talk about all the options. I'm going to give you my professional opinion, but you can get other professional opinions, and I think you really should. Mm-hmm. But maybe this will start you off on this journey to make the right decision for you. Okay.
Let's get into it. If you guys aren't watching us on YouTube, you certainly can at Jason Martin MD. We've got some slides, but we're going to read and talk about everything on them as well.
Okay. So breast cancer is the leading cause of cancer-related deaths in women. 15% of all new cancer cases in the U.S. Are female breast cancer cases. So it's amazingly common. A 5-year survival is fairly high for all breast cancer patients, so it's almost 90%. So it's a very treatable cancer, unless some of the later stages, if it's more progressed. Mm-hmm. And those are still treatable, but the numbers change a little bit.
It's a shocking difference. So localized and regionalized breast cancer, your survival rates at 5 years are 98.9% and 85.2%. But when you have distant or metastasized breast cancer, survival rate at 5 years goes down to 26.9%, which is pretty devastating. That's a very low percentage.
Right. Which is why organizations like Komen and cancer organizations really promote mammograms and screening.
Early detection.
Because early detection really decides survivability in many cases. Now, if you're listening to this and you're a later stage patient, I've had, anecdotally speaking, patients with later stages who have survived. Mm-hmm. The medications have gotten better. I personally go to a tumor board every week where we talk about breast cancer treatment. And it's amazing the new drugs that are coming out, chemotherapy drugs and treatments.
Well, more targeted chemotherapy, yep, too, that's much gentler on the rest of the body.
Exactly.
And the rest of the, yeah.
And the new kind of radiation protocols. So if you're in that boat, don't give up, but you want to catch it early, mm-hmm, and you can see these numbers really represent that. 250 people were diagnosed with invasive breast cancer in 2016, or 250,000, excuse me.
Do you know what the percentages of men versus women that are diagnosed with
men
breast
are
cancer?
like less than 2%.
But that's still pretty high.
Yeah.
2%.
And so you can get into breast cancer treatment and awareness, and it gets into a lot of problem areas. I was actually on the Komen Appropriations Committee for Colorado, so we would help decide where the money would go that people would donate to
the grants.
Yep. The grant committee to make sure that the money went to the places that people needed it the most. So they obviously needed doctors and stuff on that to help them understand. And there's so many different subsets of the population that are not really fully accounted for in terms of prevention and diagnosis and all this kind of stuff, screening. And men are one of them. Mm-hmm. In the African American community, it's harder to get the word out, especially in people that don't speak English, like the Hispanic community, first generation, stuff like that. So Asian community. So I think that that's one of the big things of these organizations that work with breast cancer is to get the word out. I know in our area up in Vail, the Shaw Cancer Center, which is an amazing place, that's a big part of what they do up there. Is to try to get as many people to get the mammograms. Make sure you capture these things early because it is a treatable disease. Which
is interesting because the recommendations for when to start mammograms seems to have changed so much in the last few years. Like last year, I know when I went in for my annual exam, I was concerned because I do have a family history of breast cancer, but because it's on my dad's side and my grandmother was over 65 years when she was diagnosed, they said that I'm not at higher risk.
I'm so happy we're not talking about this topic today because at our breast tumor board conferences, it's so confusing.
Yeah.
The criteria for genetic testing is changing.
Yeah.
I mean, that alone would be a great podcast. So, but you're absolutely right. And they don't know the answer right now. So,
yeah. And it can be confusing.
They've even said, some organizations said self-breast exams are not important. Meanwhile, I've had more than a handful of patients who have found their own masses on their breast.
Most of our patients, I feel like. At least
And they felt something and they went and saw the doctor and it was something. So
or a partner, felt
Right.
it. Yeah.
So it's, breast cancer is very common. I think, and I think we have a slide here, but it says 1 in 8 women in the U.S. I think that's actually lower now. I think at one place I read is 1 in 6 or 1 in 7. So can you imagine 1 in 8 women? Let's just go with that number. So in a room, if you're in a room full of 8 women, just by statistics, that one of those women is going to have breast cancer. Mm-hmm. It's truly devastating. It's very, very common. And so when you start seeing these numbers and you realize the full scope of this, and that works worldwide, Western Europeans have a higher incidence of breast cancer, whereas people that are Asian and African have a lower incidence. So, it's not as common. But whatever the case is, 1 in 8 is really devastating. And you can see why there's so much attention and money spent on breast cancer, both on awareness and for treatment.
Well, and I think that this other statistic is really telling as well, that breast cancer is diagnosed every 29 seconds around the world, and in the U.S. every 2 minutes.
Yep.
That's crazy numbers. Like you said, statistically, you're, as a woman, like that another woman or are related to another woman who has or will have breast cancer is extremely high, or that it will be you yourself. Like, those are pretty scary odds to look at.
So what we're talking about today is breast reconstruction. We're going to break it down into the basics of breast reconstruction. We're going to talk about what that means. Primarily, this is about reconstruction after a mastectomy. A mastectomy is obviously surgical removal of the breast. There's different types of mastectomies. We're not going to really delve into that too much, but in general, if you have to have your breast removed because of breast cancer, many times, and hopefully all the time, you're offered a means of reconstructing your breast to make it look at least somewhat like it did before. Mm-hmm. And in rare cases, make it look better. And I've had those cases, few and far between.
Well, and better is subjective.
Yeah, better is subjective.
I would argue most women would rather have their saggy natural breasts than to have had breast cancer.
That's a very good point. But if you can put a silver lining in that, maybe
True.
You can make your breasts a little bit bigger than they were, or less
perkier.
saggy. Mm-hmm. Yeah, less saggy. That's good. Okay. Yes. So a mastectomy is what we've done for a long time. I trained in general surgery, and some of the greats, Halstead and all these other names in general surgery. This has been a common surgery we've had for many, many years. Mm-hmm. The mastectomy is meant to remove the breast tissue, and which is great for treatment. Almost always with a breast cancer diagnosis, you're going to have a sampling of your lymph nodes. If you have a known problem in your lymph nodes, you may have a full axillary lymph node surgery, which removes a majority of the lymph nodes in that area. But if you don't have a known lymph node problem, and that's something that could be diagnosed with just a small biopsy with a needle, or even an MRI sometimes, what we'll do is something called a sentinel node biopsy, which will sample the nodes in that area, the sentinel node or the primary node where the breast drains, and see if there's cancer in that area. So the other option for people besides a mastectomy is a lumpectomy with radiation. Mm-hmm. And the outcomes in terms of survivability are the same, supposedly, with both those surgeries. So again, I'm not a general surgeon, I'm a plastic surgeon. I'm kind of paraphrasing what the general surgeon I work with says to our patients, but they're basically similar. So your outcomes are very similar. Some people can do breast conservation, a lumpectomy, just removal of the area where the breast cancer is with radiation. Other patients choose to have a mastectomy. Mastectomy has the benefit of maybe having a lower local recurrence rate, but survivability or long-term survivability is not any different. So you as the patient, if you choose to do a mastectomy, that's your choice, because you have in a thing that you have very few options. In most cases, you'll have an option of a lumpectomy with radiation and mastectomy. In some cases, and this is not as common, people have more progressed disease, so they have a bigger area of disease. They have multifocal disease in different areas of the breast. They have a genetic background, which we're not going to go into in this podcast, but like BRCA1 or 2, it runs in their family. So in those cases, you're probably going to lean more toward the mastectomy. There's clinical situations where you would get a mastectomy. So what we're talking about today is primarily reconstruction after a mastectomy.
Can I ask you one question about that?
Please.
On that same vein? What's the deciding factor typically, from what you've seen at the tumor board, of whether it's bilateral or not?
And
Like
that's
if the cancer is focal on one
gosh,
side.
you're opening up every Pandora's
I know.
box. This is supposed to be an educational, transformational podcast. Every woman with breast cancer watching this was like, "Oh, please, Dr. Martin, don't make me nervous about anything." So you're bringing up all the hot
But
topics.
it's a good question because a lot of women do opt for bilateral mastectomy even when their cancer is on one side.
Right. So if you have a genetic component like BRCA1 or 2, and there's different types, you will get, or they will highly recommend bilateral or both-sided mastectomies. So removing of the right and left breast, because what is true for the left side, if that's the affected side, is going to be true for the right. You're going to have a much higher rate of breast cancer, rate of getting breast cancer in your lifetime. For these BRCA patients, and again, I'm not a geneticist, it's somewhere around 70 to 80% will get breast cancer in their life, which is crazy, right? So you would remove both breasts. Other people choose prophylactically remove the opposite breast. And in almost all cases, insurance companies will cover that.
Right.
And they do that for peace of mind. They do that for, maybe decreasing the chance of having a breast cancer over on the opposite side, the non-affected side. Some people choose to do it just for symmetry purposes, to help with reconstruction. There's different reasons to do that. And then there's also actual pathology. Depending on the type of breast cancer you have, some of them have a higher incidence of having contralateral opposite side cancers. So that gets a little bit more complicated, but in those cases, you might recommend a both-sided mastectomy.
Bilateral. Okay.
Now, real quick on this, we do reconstruction. We'll talk about this at the end for lumpectomy sites, right? With radiation. You've seen me do that many times. And we usually do it with fat transfer or even sometimes implants. So a majority of what we're talking about today is reconstruction after a mastectomy, but you can also reconstruct your breast after a lumpectomy with radiation. Let's go to the next one. All right. Types of skin-sparing mastectomy incision. So when you do a mastectomy, there's all different types of incisions. And the reason why I'm talking about this is that it will affect your type of reconstruction you want to do. Most of the time, if you go to a reputable area and you're going to have breast cancer surgery, they're going to try to maintain as much of your skin of your breast as possible, right? Now, that could change if the breast cancer is near the skin, or if you have multifocal disease, or if you have problems in a lot of areas of the breast, that could change the whole surgery. But this, all comers, we try to maintain and salvage as much of the skin as possible. The incision, if you look on YouTube, which really does show this well, Jason Martin, MD, our channel there, you can have incisions around your areola that remove the areola. That can be a circle or a fusiform, like an eyeball shape, or aperture shape.
Yeah.
You can do more of like a breast lift incision, which is around the areola and straight down the midline of the breast, or an incision that goes on the outside of your areola towards your armpit.
Yep, like a lollipop on its side.
Yeah.
And this is interesting to me too, because I feel like years ago, like 10 plus years ago, we did very few nipple-sparing mastectomies. And is that just because the technology for understanding the blood flow to the flap wasn't as good? Or
right.
It seems like that's a far better option, because that, there's no tattoo. I mean, the tattoos are really good, or anything else that can really replicate a nipple when it's gone.
Right. So what we just talked about was the skin sparing, so the nipple and areola are removed. And in most cases, historically, that has been the case. But what we've seen in the past 10 to 15 to 20 years is a really surge of doing nipple-sparing mastectomies. So what is the risk of keeping the nipple and areola?
You're keeping you have to keep tissue to keep blood supply to the nipple and areola,
right.
Or else it will not make it. It'll be non-viable, which means you're keeping those ducts. You're keeping some part of the breast tissue.
A lot of cancers, breast cancers, come from the ducts.
Yeah. Or right behind the nipple and hard to find.
Yeah. Invasive ductal, breast cancers are basically the most common type, or I believe are the most common type, and they come from the ducts. The ducts are part of your nipple and areola, and that's where you make milk for babies. So if you leave the nipple and areola behind, no matter how good the surgeon is, you're still leaving, theoretically, some breast tissue there. We still highly encourage people to do nipple sparing purely because it has a better aesthetic outcome. Secondly, the only time that you really can't, it's like contraindicated or you shouldn't do it, is when the cancer is like right at that nipple and areola. Directly and so you would be, your margins of getting around the cancer would be very small, or you're kind of pushing the limits with really no value to the patient. Sometimes if people with aggressive cancers, they'll take the nipple and areola, but many times we try to push people to maintain their nipple and areola because it makes the reconstruction that much better. So, and that's where, this next topic really is about the nipple sparing mastectomy. And that's what, at least in my generation, or since I've been out from training, which is getting to be longer and longer these days. I keep focusing on that. I'm feeling old, Dave. Feeling old.
Well, we're getting old at the same rate.
I know. So, you can do an incision at the base of the breast along your inframammary fold, the fold of the breast where the breast meets the chest at the bottom. You can do an incision that goes from the nipple and areola to the armpit, like out in that direction. That's a common one that the surgeon I work with does a lot.
That's the first time I've seen you do those. That was really cool.
Yeah. You can do ones that just have the incisions around the areola but don't remove it. And this bottom one is more of a mastectomy incision. I don't totally understand that. Anyways, that's preferred from a reconstructive standpoint. So if you have a diagnosis of breast cancer and you are going in to talk to your surgical team, and it'd be really nice if you have a breast cancer team, by the way, where you can meet with the general surgeon and the plastic surgeon, but it doesn't always work out that way. Talk to them about trying to do a nipple sparing mastectomy because it will make your reconstruction better.
So much better.
Yeah.
And we've tried. I mean, there are things that come up, and we'll talk more about the incidence of complications later, but it's really sad when you've done so well to save a nipple and areola and then something happens and it is not viable.
Right.
And that can happen because you have to think about that. The blood supply that innervates that nipple and areola comes from way behind and goes through that tissue. And
right. And that's the one thing that I think people need to understand. When you do a mastectomy, you absolutely violate the anatomy of the breast. Most of the blood supply to the skin and the nipple and areola, for that matter, don't just come. Some of it runs along the skin, but some of it comes from deeper and kind of shoots up like a tree. And when you violate that, when you do a mastectomy, you really do leave the skin and soft tissue that's left over after a mastectomy at risk. We have these newer devices now. One of them is called the SPY, which can evaluate intraoperatively the blood supply to the flap, which is really cool stuff. Yeah, it uses this fluorescent dye that you inject in your bloodstream, and then you can watch. It's amazing. Real time as the blood supply, you can see how well it's perfused or not perfused, meaning the blood supply to these flaps. But even that alone is not perfect. So you always run the risk of having vascular compromise with this, and that's one of the main concerns related to a mastectomy. Primarily, though, so let's just say you've had your mastectomy and you want to know your options. So, Amy, let's go through the first and most common option, which is placement of a tissue expander.
Yep, so two-stage reconstruction means that you first have a tissue expander put in place, and then we'll come back secondarily after that tissue expander has been expanded to the volume we're going for, then take that expander out and put the permanent implant in place.
Right. The first stage is at the time of your mastectomy. You have your breast tissue removed, and then the plastic surgeon, someone like me, comes in, and they place the tissue expander. In most cases, they'll place it underneath the muscle. I've been doing it above the muscle, and we'll talk about that in a second, which I think is really good. But they'll place the tissue expander underneath the flaps, and the tissue expander will describe in detail what that looks like. But that's going to be useful as we move forward because you'll, over time, after the mastectomy, after you start healing, is we'll expand out your breast or to get it to a desirable, I guess, volume or size, right?
Yeah, the volume that we're
and then
needing.
You'll come back secondarily and put a permanent implant in. What's the normal time frame for that expansion, Amy?
I'd say anywhere around 6 months to give the expansion time, everything to time to heal, do the expansion, put in the permanents. Now that can be altered drastically based on their post-operative plan as far as chemotherapy and radiation go. I mean, there are times when that has to be extended.
So the 6 months usually is with the radiation. We'll get into that too. It can go as quick as 6 weeks. If you don't need radiation and you did a nipple sparing mastectomy, and so you really don't need a lot of expansion.
Fast expansion.
Yeah, exactly. And then once the expansion's done, if you didn't have to expand it out a lot, I mean, in some cases you could do it within 6 weeks or 4 to 6 weeks, but it's between that 6 week mark, and depending if you need radiation, could be at least 6 months till you get the second surgery, or up to a year. And it really does depend on your pathology and what your surgeon finds in those lymph nodes. Those lymph nodes are really going to decide, if you didn't know it preoperatively, If they weren't sure preoperatively, those lymph nodes are going to tell you if you need radiation postoperatively. Or also, the other reason would be is if your margins were really close, but not positive, then they would do radiation too. So tissue expansion is the most common type of breast reconstruction that we do in plastic surgery. Now, no matter what a plastic surgeon tells you, it's not the most aesthetically best outcome. But it's the easiest thing to facilitate. People get a little bit frustrated about having to do 2 surgeries, but the second surgery is extremely well tolerated. Rarely is it a problem. And before you know it, it's done. And in most cases, people are don't have too many complaints. So it's definitely doable. It's not hard to overcome. I don't want you to worry about that if you are worried about having 2 surgeries. And it's the most common type of reconstruction we do in the United States. Placement of the tissue expander has to be done in a correct way. You have to place that tissue expander right perfectly in the anatomy of your breast. The tissue expander, the bottom part of it, has to be right at the inframammary fold, and that's going to make a good outcome. Making sure that your general surgeon, when they do the mastectomy, preserves the inframammary fold if possible, will make a better outcome too. And the expansion, overall, when you start expanding, should take you at the most 4 weeks. 5 weeks, 6 weeks. We've had a few patients, Amy and I have had, where they really couldn't tolerate the expansion. We had to do it really slow.
Slow process.
Yeah,
Yep.
that was, a month at a time. You do a little bit and a little bit. The reason why they can't tolerate it, and this is at least historically speaking, is almost always, historically speaking, we put the tissue expander underneath your muscle. Which muscle is that, Amy?
Pectoralis.
Pectoralis major muscle. And when you expand that out, just like with a breast augmentation for cosmetic surgery, it really puts a lot of pressure on your muscle and leads to muscle spasms, and muscle spasms of the pectoralis major muscle are really uncomfortable. So we would usually give Valium in that situation or some sort of muscle relaxant to help that.
The benefit of that, though, is you've got the protection of the muscle, because you think after a mastectomy, sometimes it's just skin. It's like skin and muscle is all that's left. So if you were to put it directly under that skin, and then you've got a lot of weight of that expander pushing out against that flap, I mean, that was historically what we were concerned about.
And also show of the implant itself. Like, you didn't really have a lot of coverage of the implant, very thin skin flaps, and you put a tissue expander there. Every problem with a tissue expander you would see. Whereas the muscle, the pectoralis major muscle, gives you some coverage.
Yeah, give you a little bit of shadowing, at least, a little bit.
So if you look, again, sorry to keep referencing the YouTube channel, but it's really helpful in this. If you look on the YouTube video, you'll see what a tissue expander looks like. It's shaped. Describe the shape, Amy.
Yeah, it's a shape. It's like a shaped implant. So, and we've talked about that before, and there are a lot of pictures online of this, and we could even put one up on Instagram. But I think pretty much every woman understands what a shaped implant looks like. It's more of that teardrop shape. It's flat on the back and has more of that teardrop shape in the front.
It also has a built-in port. This port, if you're looking online, it has basically a reinforced area that you could stick a needle through your skin, through your soft tissue, into that port and fill it up when it's underneath your skin.
It has a rare earth magnet in it, so you use a little magnet on the surface to find it.
What exactly is a rare earth magnet?
Natural?
Okay.
That's what they call it.
Right.
So this is also an important thing to know. If you have a tissue expander in place, you can absolutely not have an MRI.
Right, because there is
a magnet in there.
There is magnetized metal in
Yes.
there, which would react to the MRI, and it would start moving in the pocket.
Yes.
So you cannot have an MRI.
Yeah, it'd be very bad.
And so over time, you come in for, in my case, most often like every week or every 2 weeks, and we'll expand that out. And sometimes it's 50 cc's. What does that equate to in cups?
Oh, like half a cup. And it's just saline. We just put sterile saline
Sterile
right
saline in
into it.
there. Sometimes 100 cc's, which would be a cup of fluid in there, distributed out through your breast that you're reconstructing. And the cool thing is that with these tissue expanders, then you can expand it to exactly what you want. And so in a situation where you feel completely overwhelmed and you have no choices, at the very least, you can pick your breast volume.
Usually. I mean, there are limits.
I know there's limits,
Yeah.
but I'm trying to make this sound better than it really
Yes.
is. Yeah. But it is a nice option, and it definitely is something that people prefer. Now, the problem with tissue expanders, I'm just going to tell you right now, is they don't really look totally normal either.
No, they don't feel normal. They
And
are not soft.
They're not soft.
Especially
they don't
when they're full.
feel normal. Like if you hug somebody with tissue expanders in place, you would feel like you have these rocks on your chest. One patient referred to it as having an elephant on her chest. So don't feel like with these tissue expanders in place, all of a sudden you're going to have this perfectly reconstructed breast. it's meant to look a little bit distorted because it wants to expand out the lower pole of your breast. If you imagine if your nipple and areola were still there, the part below your nipple and areola going toward your stomach, it really expands that area out preferentially and not the top part. And that's what creates a normal teardrop shape to your breast. So these things can fail. You can stick the needle in wrong. I've seen it before, but that's pretty rare.
Yeah, we haven't had a deflation.
Yeah. Again, as
We've
Amy
had some
said,
rippling, but
there's a rare
earth magnet.
Rare earth magnet in this, in which
it's like the size of a quarter. It's hard to miss.
It's hard to miss.
It's not like your surgeon is having to.
And we use like
thread
what's it like in the old days when they used to take the stick and it used to drop it on the water? You know, like it circles it.
Like a divining rod?
No, like there's a name.
Dowsing? Yeah.
Dowsing? Is that
it's
what
like
it's
dowsing,
called?
yeah. When they're trying to
dowsing.
like find stuff.
That kind of thing. So it has that feel to it. You're doing that externally. People always think it's pretty cool when you find it and the magnet focuses in right on the area you're supposed to stick the needle.
Mm-hmm.
All right. So tissue expansion, as we said, it happens over time. And you can usually start with at least 25% full, and you have to do the extra 75% after surgery. To be honest with you, in the new way I'm doing this stuff now, and we'll talk about that in a second, I expand them out a lot beforehand, so usually only need a couple, and that's why I've been reducing the amount of time you have to wait for the expansion. One of the ones we use is Natrel or an Allergan, but there's many different companies that make these. Mentor makes one, Mentor. Natrel is Natrelle, made by Allergan. And even Sientra. So there's 3 different major implant companies. They all make tissue expanders.
And then there are companies that only make tissue expanders as well.
Yeah,
so
and then there's some other different ones too. So
there are a lot of options.
There's one that actually...
The air one.
Fills up, has a CO2 canister in it. And you just press a button and it fills up by itself. You're like a shoe.
So patients can expand it.
I thought that was pretty cool, but the company was small and you don't want to.
Sketchy.
Yeah, but I mean it's probably not. I mean, so it's a good idea.
Yeah.
And then afterwards, on the second stage of the surgery, we use anatomic shaped implants, and you can go online and see those anywhere. Teardrop shaped implants.
Or round. Sometimes we'll still use round.
Sometimes we will, but a lot of times we'll use the anatomic shape. Now, Amy, we've talked about before, there's an episode previously in controversies in breast implants. Why don't you just quickly talk about ALCL and one of the issues that is somewhat related to textured implants, which all shaped implants will be textured.
Yes, as of now, all shaped implants are textured. Mentor is supposedly coming out with a non-textured shaped implant, but as of the recording of this podcast, the only available shaped implants from any manufacturer are textured. And as we said in our podcast about ALCL, the incidence is extremely weighted toward textured implants. It is not only in textured implants, but it is heavily weighted toward textured implants.
ALCL is anaplastic large cell lymphoma. It's a lymphoma that develops around breast implants. There's 437 cases that have been diagnosed, but I'm sure there's going to be more. And it's extremely rare, but it's something we have to understand.
Yeah. And it's not breast cancer.
Right. It's not breast cancer. It's literally a lymphoma or related to the lymph T cells or the cells that are related to your lymphatic system. And it's treatable. And in most cases, it's curable. But in rare cases, it's not. But in itself, it's a very rare condition. And I think, in my professional opinion, and this is just coming from me, I think that anatomic shaped implants that are textured are still going to be okay or cleared for people going through breast reconstruction, because the ability for it to improve the outcomes for people going through breast reconstruction is pretty high.
Yeah, and this is not, just so everyone listening understands, ALCL is not specific to women who have had breast cancer.
Yeah.
It is specific to women who have breast implants. So it doesn't mean, it happens in women who have not had breast cancer. It is not breast cancer. So it doesn't mean, like, if you're listening to this and you're needing reconstruction, don't think that your risk is any higher to get ALCL because you've had breast cancer. I mean, at least as far as what we know now, that's not the case. So any woman getting breast implants is at risk.
Right. Again,
albeit very, very small.
Yeah, it's extremely rare. And the likelihood of anyone getting it is extremely small, very, very small. But it is something important. Again, remember, we're talking about education and empowerment, that you should understand that if your plastic surgeon puts a textured implant in that's most likely teardrop shaped or anatomic shaped, which I do all the time, that you do have a slight increased risk of getting ALCL. But where that goes from here If you get radiation, all these kind of clinical things, it's really small. So I think it's not something that should hold you back, but just have that knowledge in your head. Now, what has changed in breast reconstruction in the past 10 years, Amy?
Many things. The availability of having anatomic shaped implants is probably the primary thing that I think has changed.
Associated with that change
is the increased use of sort of internal structuring or dermis replacements that have gotten better and less reactions.
Right, cadaveric dermis grafts. So these have really changed the way we approach breast reconstruction. Cadaveric dermis is literally what it sounds like. Well, I guess dermis is a medical word, but it's cadaver skin that's been removed of any...
It's been washed essentially.
Of any cells that could react to your body, and it leaves the substrate of skin without all the cells and live particles in it. We now use that, at least initially, at the base of the breast to create an inframammary fold or like a hammock that your implant would sit in. And that has drastically improved our outcomes.
And we always used Alloderm, like even way back in the day, 10 years ago, we used it, but it was not
because you work with a guy who is a little bit, forward thinking,
Yes.
but a lot of people haven't. I mean, a lot of the older plastic surgeons don't use cadaveric dermis grafts. Now, cadaveric dermis grafts, they have risks too. They increase the chance of something called seroma or inflammatory fluid, which can be a problem. They slightly increase the chance of infection, and other things that can be a problem. But in most cases, I think they're value add for sure. And I definitely think your outcomes are better.
Yeah. And they have gotten better. I mean, the thinness of them has gotten a lot better. While keeping their tensile strength, they're a lot thinner than they used to be. And there have been so many iterations of dermis on the market over the last 11 years since we've been working together. I mean, there was bovine available for a long time. There was the Stratus, the silk series, which was made out of silk fiber, almost like a grid.
They have ones made out of different types of suture material, like Vicryl material. And I mean, it's endless.
Yeah, so there are a lot. And it's all of these dermis or dermal grafts are all just trying to add strength to the area, really. So that's why there have been so many different things that we've tried, because the end goal is just to make that area stronger.
Yep, and to give more coverage. So the idea would be historically, I mean, when we started using these grafts, is to cover the top part of the tissue expander with the pectoralis major muscle and the bottom part, or the part going towards your stomach, with the cadaveric dermis graft. So what we've progressed now to is actually not even putting it underneath the muscle, and actually kind of going against what Amy said, but she was absolutely right about what she was saying, is actually use thicker pieces of cadaveric dermis and wrap the tissue expander around. So why is this positive? Number one, you don't violate the muscle. The biggest painful part of a breast reconstruction is violating the muscle. It's very painful. And if you don't do that, I mean, literally the first case I did this type of procedure on, the patient was like, yeah, I'm fine. And I was like, are you sure? You don't have pain? And she's like, no, not really. And we'll get into some of the anesthesia things we've been doing too to help with pain after surgery. But you wrap the tissue expander with this cadaveric dermis, and that gives you the coverage. You remember we talked about before that if you just put it underneath, above the muscle and underneath the skin, that you'll see everything will show through. Well, wrapping it around this like a present or a blanket covers up a lot of the asymmetries and gives you more coverage for that tissue expander, especially if your skin's thin or after surgery you're having some problems healing. It gives you some protection on that tissue expander. Now, if you look on our video, it shows basically that the cadaveric dermis grafts are sewn to the muscle, and the tissue expander is kind of engulfed by that cadaveric dermis grafts. What I actually do is wrap it around the entire tissue expander and purse string it at the bottom.
So then when you take the expander out, you take all the dermis out with it?
No. But then the dermis grows, and thank you for bringing that up. So why do we use cadaveric dermis? Thank you.
Because it integrates, integrate.
Right, exactly. Your body integrates into it. It grows blood vessels and everything into it, and it incorporates it into its body. The body is an amazing thing that it does that. And literally within 4 to 6 weeks, you can already see that ingrowth. So when you go back in and put the permanent implant in, you don't take the cadaveric dermis out.
How do you get it off? So but you have to then lift it all the way up. So if you've purse string toward the back of the
back of
expander,
it, right? And
so
you make an
you
you make an incision
cut around it.
You make an incision in the cadaveric dermis
Yeah.
just like you would normal skin.
Oh yeah, and then just
pull it out. Yep.
Yeah. All right.
So, pretty amazing
That's
stuff.
cool.
This pre-pectoral technique mixed with, and that's when you place the tissue expander above the muscle, not below it, mixed with some of the newer stuff we're doing in anesthesia, these paraspinal catheters and blocks, or in some cases PECs 1 and 2 block, and we have a YouTube video on that on Jason Martin MD.
We have a podcast about it with Dr. Merrill.
Oh, Dr. Merrill.
Yep.
Yeah, sorry. We have an episode with Dr. Merrill.
That's really fun.
Forgot.
That's a really good podcast.
He talks about the PECs 1 and 2 block, and that's primarily he talks about for cosmetic surgery, but it applies 100% to breast reconstruction. It is absolutely amazing the outcome. So if you have been diagnosed with breast cancer, talk to your surgeons about this. Talk to them about the regional blocks that are occurring, because it can absolutely change your course of recovery.
Mm-hmm. Yeah, and these longer lasting blocks, if you listen to the podcast, Dr. Merrill explains what they use and where they put them, but they provide pain relief directly to where it hurts, essentially. So instead of giving you like an oral or an IV pain medication that's kind of impacting your entire central nervous system, essentially, to try and like make you think you're not in pain, sort of. A lot of those really heavy drugs are hard for people to handle, whereas this is actually putting the medication directly where it hurts. So, and the effect can last for up to like 3 days in some patients. Yeah. So by the time you're feeling it, it's to a manageable point. You're kind of over that hump of those first couple of days of more intense pain.
In one of the places I work in Vail, Colorado, they have a whole regional team, so regional anesthesia team, so obviously surgeons tend to do multiple cases a day. So say we do our first case. By the time that I come out to see the next patient who's doing a breast cancer surgery, so it would be a mastectomy with reconstruction, they've already had the catheters placed, everything's done. I mean, it's amazing.
That's awesome.
Yeah, and then they get discharged. Those catheters come out usually day 3. The patient pulls them out themselves. They're very, very small, smaller than a cocktail.
Toothpick?
No, like the cocktail straws.
Oh, yeah.
Do they even have those anymore?
Cocktail straws? Yeah, they're in everything. Like, have you ridden on a plane lately?
Yeah, that thing. The stir straw.
Oh.
The Starbucks. No, that's wood. Okay, whatever. So what the old school cocktail straws. And yeah, it's absolutely changed the recovery. So if I was going to do breast reconstruction and I wanted the best outcome with the least amount of recovery and just to be able to get on my feet the quickest, I would, if possible, if indicated, and you have to talk to your board certified surgeons about this, get a pre-pectoral reconstruction with cadaveric dermis grafts, preferably a nipple sparing mastectomy if possible, and that's what I would choose. Now, it doesn't mean it's the best aesthetic outcome, but I feel like it has one of the best aesthetic outcomes, especially at least with implant reconstruction. Mm-hmm. Okay. One last thing is you will have drains after surgery. These are always really annoying. Cadaveric dermis can cause some inflammatory fluid, so you'll need drains. And that's good at least for 7 days, usually 10 days.
Yeah, they really drain a
lot.
But
with this approach, with the blocks, you probably won't need narcotics and what we're seeing is 3 to 4 days for our patients, and they're done. So, and that's great. Less nausea and vomiting, less constipation, less headache, less brain fog. Get on with your life. Just get cured and move on. That's the way it works. All right, so Amy, so we've talked about implant reconstruction. Mm-hmm. What is the other general type of reconstruction?
The tissue reconstruction. So using tissue from your own body to recreate like a breast mound.
Right. Historically, this has been something called a tram flap, TRAM flap, and not to get too far into the words, but it basically takes the tissue and the muscle from your abdomen and basically rotates it up to your breast to reconstruct your breast, right?
Yeah. And you have to, of course, have enough tissue for that to happen.
And that can be a problem in Colorado sometimes.
Yes.
But you have to have enough tissue there to reconstruct the breast to make it look like the other side. Mm-hmm. Now, why is it better to have your own tissue for reconstruction than an implant?
I mean, there are a lot of reasons. I immediately go to the risks associated with having breast implants at all. That you eliminate those.
Which are what?
ALCL being a primary one, but also just the upkeep of an implant.
And then capsular contracture, scar tissue.
Yeah, and just that's what I mean, like the upkeep.
Yeah. So let's get into that real quick. So with implants, what do we say that with implants, it's not permanent surgery, right?
It's not. No, implants are not a permanent. They're not a permanent implant. So you will at some point in your lifetime need to have surgery on these again.
Yeah.
Like directly related to your implants, whether it's capsular contracture,
Which
other
is
types of scar tissue that
Yeah.
have formed,
Asymmetries.
droopiness, like
Yeah.
things. Your breasts continue to age, so things change.
Especially if you get radiation. Radiation is really destructive no matter what the radiation oncologist says, but we have an amazing radiation oncologist. I work with Dr. Hardenberg, but it can really change the aesthetic outcome from implant reconstruction. So using your own tissue has a real big benefit. Aesthetically, it's better, and it's more longer lasting. If you get it right, then you really don't have to do much in the future.
Yeah. That's what I mean. There's no upkeep.
So why doesn't everyone just use their own tissue?
Well, you have to have enough, and
Right.
you need a microsurgeon.
And it's a pretty big surgery.
It is. It's kind of like 2 surgeries. I mean,
Yeah.
it's basically taking your mastectomy and then also adding on a tummy tuck.
Yeah.
Or, if you're doing a latissimus flap, you're having a big scar. And I remember specifically there was one patient who we really were trying to push toward a tissue reconstruction. She was a great candidate for it, but her big concern was she was a climber. And there was no way that she wanted to have the potential of disrupting her latissimus muscle because
Which
for
is the
her,
back muscle, yeah.
quality of life for her climbing, that's a muscle that you use to pull yourself up with. Her concern was she didn't have enough on her abdomen. So she did not have enough tissue on her abdomen for reconstruction there.
Right.
And so she decided to do implants because
it's a much more involved surgery. And I don't want to use the word major surgery, but you're talking about hours, 7, 8 hours, if you do it at the same time of your mastectomy.
Yeah. So it's like combining mastectomy with another big surgery.
Right. In Denver, we have really good autologous tissue reconstructive surgeons. But, for anyone listening to this and you're just trying to find out information, you've been diagnosed, if you don't live in a big metropolitan area, you probably don't have someone that does these surgeries on a daily basis and well. So you literally have to go to those places. There's regional centers. We're lucky in Denver to have that. I work in Vail, and I'll send my Vail patients down to Denver to go to some of these people that do this.
Mm-hmm. Yeah, just because it's not available where you live, if you live in a small place, doesn't mean you should not seek it out as an alternative.
Right. As Amy said, you can use your latissimus muscle or back muscle to rotate that around. So we can rotate your stomach muscles with skin and keep that blood supply open and non-violated, or you can do the same thing for the back muscle and bring that around. A lot of people in our area don't like to do that surgery because they are active and do things that are related to your latissimus muscle, like cross-country skiing, rock climbing, swimming, mountain biking, just kind of holding a certain position. So here it's not as common maybe than in other areas of the United States.
Have you ever done a gluteal flap?
No. That was after my time, to be honest
with you.
Or a tug
flap?
It was when I was going through these these gap flaps, they call them GAP flaps. It was right when I was going through, again, I'm harping on my age, man. I'm harping on my age. So those are this coming out. Those are there's a lot more difficult to do and but just real quick. So what we've talked about up to this point are flaps that are still on their blood supply. Mm-hmm. But now what we've gotten to in our plastic surgery, which is really cool stuff, which is called free flap reconstruction, where you actually take the tissue off and you reimplant it somewhere else. Mm-hmm. You isolate the blood vessels, so the veins and arteries for the flap, and then you reattach those up in the chest area. And what you'll do in most cases is remove some cartilage in one of your ribs, and there's some blood vessels near your sternum that they'll use and hook this up. And it's amazing that you watch them harvest this tissue with the blood vessels, and then they hook it up and you see it perfuse. It comes alive.
So crazy.
Like immediately. It's kind of crazy stuff.
Yeah, that pump works.
And so when I do my surgery, sometimes I go watch. I just love it. And they're like, "All right, man, we know it." They're like, "Okay, great. We see this every day." And I'm like, "This is so cool." Anyways, these are great flaps. Now, one of the most common ones we do now is called a DIEP flap and a deep flap, and you can get into all the words on that too. We're not going to confuse everybody today, but the reason why these flaps are so good is now they're doing muscle sparing. So they're really not taking any part of the muscle. The problems with the old school rotation flaps, like the tram flaps or latissimus flaps, is that it would take part of the muscle, like we talked about. And that would have a big effect on abdominal contour, your stomach contour, and more importantly, on your functionality. And now doing these free flaps, you can do it in a way that you can salvage that muscle. And that's where the game has really changed.
Yeah.
Yeah.
Again, like the thing you definitely need with that is to have enough tissue in the area of harvesting, and then also to have an amazing microsurgeon, because as Dr. Martin described, you're basically hooking tissue up to new blood supply. So you got to make sure it's all there.
Yeah. It's few and far between these specialists.
Yeah. You
really have to do your research. So I highly advise you to look into this kind of stuff, but it is kind of a big deal. And these are really long surgeries. To know that if you have enough tissue or not, if you're sitting down, how would you describe it? And you could really grab, if you're in a sitting position.
You can grab your stomach roll, essentially.
And you have a decent amount of tissue
More
there.
than like an inch. It's not just skin.
Yeah, and it has to have some fat there, because obviously you have to recreate the breast as it was before. So that's free flap reconstruction, which is really where the plastic surgery has gone in the past 20 years, and it's really changed our field with breast reconstruction.
And the aesthetic outcome of the ones that I've seen of patients of ours who've had this done, it really is remarkable.
Right. So no question, from someone who does implant reconstruction a lot, it's better than implant reconstruction. But is it 100% better? No.
And there are issues with it as well.
Right. And we can talk about that quickly. There's 20 or 30% better? Yeah, maybe. And a lot of people don't choose it just because of the sheer involvement of the surgery, and they don't want more scars, and they don't have the tissue, or
they don't live in an area where it's available and they can't travel.
Yeah, which is unfortunate. It just makes it makes you feel bad for those patients, because one thing we want, and the reason why we're doing this episode, is just so you know you have options and that you educate yourself. We talked about previously that if you've had a lumpectomy with radiation can really change your soft tissue, that using fat transfer can also make a big difference for your breast.
And in some cases, even with a well done or a nice outcome from a reconstruction, a little bit of fat transfer, because remember, again, all that breast tissue is gone. So just to give a little bit more cushion, to areas around the implant that might have show, or, textured shaped implants tend to be a bit more firm, to kind of soften those a little bit. Putting some fat in is nice.
Right. So almost always, especially for me, because I'm more getting on the perfectionist kick on this stuff, is if you've had an implant reconstruction, or even a deep or autologous tissue, a free flap reconstruction, a lot of times you'll have little asymmetries, a sharp curve, a sharp turn. It just doesn't look natural, and we'll use your own fat secondarily and inject it into the areas where you need it. Yeah. So, and we do that all the time.
Yep.
So I would say even on good outcomes, we'll still do it sometimes, depending if the patient wants it or not. And it works really well. Taking your fat from your stomach or your flanks or your sides, your hips, and injecting it underneath the skin and areas around your breast, it has a really good take. If you've had radiation before, the radiation will lessen the ability for your body to have that fat transfer work.
Yeah, just because the blood supply is limited.
Yeah.
Now, here's a good question for you, Dr. Martin, that I'm sure some women would want to know. Why then can't you just do that to reconstruct a breast?
Because you can't. That's a very good question. You're full of such good questions. So
I know what I'd say, but
yeah. But number one, you can't inject enough fat to make a difference. Fat, when you inject it, when you take it from one area of your body and go to another, your body is really amazing at how it absorbs, like the cadaveric dermis grafts we talked about. The problem is it needs to be closely approximated to your native or your natural blood supply. The small, teeny blood vessels that you can, you'd have to look at a microscope. And if you just keep injecting fat, at some point you're injecting fat surrounded by fat that you just injected, and there's no blood supply in that, and it just won't take.
Yep.
So there's only so much you could do. Now, over time, there's who was that guy in Miami who would do that tissue expansion with the breast and keep for cosmetic reasons, and then externally, like a suction cup on the breast.
Or put fat underneath it.
And do it in serial fashion over and over and over, and keep on doing that. But that's super involved, whereas most people wouldn't do that. And in the case of a mastectomy, it's just not going to work.
Yeah. And I think most people can kind of understand that too. Like, you need structure that is now gone, and fat alone is not going to provide that. So what are the things that bother most women about excess fat? It hangs. It's not tight and taut. It's fat. It's loose, it's jiggly. It doesn't have a lot of structural stability to it. So if you're needing to reconstruct something like a breast that is three-dimensional and has structure to it, breasts are full of tendons and ligaments to keep it up, just shooting as much fat as you can in there is never going to be that fix.
Right.
It's never going to be that.
That's a really good point.
It's good to soften areas and provide like little bits of finishing touches to things, but on its own, it would never be a viable option for reconstruction.
It's more of like kind of taking your finger on chalk and kind of rubbing it out, blurring it out a little bit. That's a really good point. Yeah, and you know, your native breast, we didn't talk about. I probably should have talked about the anatomy. It has something called Cooper's ligaments, which keep your breast in its shape. And obviously, those Cooper ligaments get stretched out with pregnancy, and that's why women come and see me cosmetically.
Yes.
Yeah. So you know, just using fat are not going to give it that structure it had before.
Yeah.
Comparison of 2-year complication rates. This was in JAMA. You can get different types. It says 26%.
JAMA's the Journal of the American Medical Association.
Oh, yeah. Sorry. JAMA.
JAMA.
The American Society of Plastic Surgeons has its own journal, which is the White Journal, and they have data like this too. So this I'm only putting this slide in here. I don't want you to just take these numbers to your surgeon and say that JAMA said. But there's definitely a high complication rate with all these surgeries. Mm-hmm. Overall, it's 32%. It's 26 for implant-based and 46 for autologous or your own tissue. But I think that the implant-based is actually, that's low. I think it's even higher, especially if you add radiation on. But these complications aren't really like, it just doesn't work, right?
Right, it's not failure.
Failure below, there's a higher failure rate with implants and a lower with your own tissue. The complications are like an asymmetry, fat necrosis, a seroma, inflammatory fluid, infection, blah, 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 loss of skin, loss of tissue, all this kind of stuff. And it can vary across the board. All of them have a high complication rate in comparison to standard surgery. In cosmetic surgery, which I do a lot of, if I told someone you have a 35% chance of having a problem with the surgery, they would say no, right? And these are the real difficult conversations that we have with our patients. We're very honest with them. Now, my complication rate or the numbers they show here are lower than what they're saying on this slide or what we just stated to you. But that's because, number one, because my patients are very healthy here in Colorado. They don't have high blood pressure. They don't have diabetes. They rarely smoke. In most places in the United States, somebody even listening to this podcast may smoke or they may have diabetes and high blood pressure, and that's okay.
Or be obese.
Or be obese or obesity, a BMI over 30. And that's okay, you know, because you still have to deal with it. We still have to deal with this problem that we have, which is breast cancer and reconstruction. And so your complication rates probably will be a little higher than the standard patient I see in Colorado. Mm-hmm. And that's just reality.
Yeah. Well, if you think about it, I mean, you're basically in any of these situations doing multiple surgeries at once. So anytime, and this is true for cosmetic surgery, that we're doing multiple things or adding in an implant, like your risk goes up incrementally of having complications just due to the other things you've added in. The risks that then become inherent to breast implants, the risks inherent to a tummy tuck if you're having a deep flap. Like those things kind of combine on top of each other that might alter your complication rate overall, but you have to think it's not just the reconstruction that you're
and complication rates with using your own tissue, a complication could be bad scar or the complications don't mean it doesn't work.
Right.
So, and that's where you get into the nitty-gritty of the numbers and the definitions and stuff like that. So that's pretty much it. If you have breast cancer, just remember it is curable. That's good. Secondly, just remember you're going to need surgery most likely. This surgery will be a lumpectomy with radiation or a mastectomy. If you're getting a mastectomy, you have two choices. One is implant reconstruction, and the other one is using your own tissue.
There's a third option.
Using your own tissue in an implant?
No. I mean, the other option is...
Oh, yeah. That's a good...
You don't have to have a reconstruction.
Right.
And there are women who choose not to.
And I've had more than one of those.
And those women embrace it, and that is totally fine.
I actually totally agree with it. So it was very interesting. I had a conversation with a lady who had breast cancer. She was a little bit older. She's like, I don't want to reconstruct it. And she was almost apologizing to me because I had spent the time to talk to her about the options. And I think she knew the whole time that she was
like, no.
And I think she was looking at this like, this doctor's a nice guy.
Let him keep talking.
Let him keep talking. It was like a 30-minute conversation. And it was actually really inspiring. And I told her, I said, I support that 100%. You know why? Because it's your choice. Yeah. Like, this is what it's all about. You heard everything I had to say. You weren't down with it. I'm good with that.
Yeah, your body, your choice. And even in the best case scenario, as we've said, breast reconstruction is still not what we'd love it to be.
No.
It's not perfect.
If we know that it has 30% of the cases are going to have some issue after surgery, and it's probably higher than that, to be honest with you, that problem number goes even higher with radiation. No matter what anyone says to you, radiation is going to make more things occur after surgery. If you do an implant, you're guaranteed having more surgeries down the line if you care. An adjustment, implant exchange, take out scar tissue. If you use your own tissue, the benefit of that is it has a better aesthetic outcome, but then and you don't need to do stuff down the line, but it's a much harder surgery, and not many people can do it. And when things go problematic with that surgery, they become a real problem, right?
You think of all the complications that could happen with a tummy tuck.
So now you can understand, if you're looking at all that, like, maybe I won't do anything. Yeah. But that's few and far between. That takes a very special type of person. Amy can attest to this. She can think from her opinion. For me, I'm not a woman, but just from my mindset, I would try to do something probably to reconstruct it to make myself feel a little bit more whole. Yeah. And to close, like we said, close the door and move through. But when I talked to this patient, she was like, "Yep, nope." Yeah. And she had made up her mind before she even came in.
Yeah. And that's great.
And I do think that talking to other people who have had breast cancer, talking to people that have had breast reconstruction, sometimes you don't feel like you have a lot of time because you're trying to work through the treatment options.
You do sometimes feel very rushed.
Right. Yep. But even if you slow down your team a little bit so you can say, hey, can I talk to some other patients that have been through this? Can I
see pictures?
Can I talk to the anesthesiologist or the surgical team? That kind of stuff.
And get a second opinion. Like you can get a second opinion.
Yeah, second opinions are really good too.
Yes, and I think a lot of women, especially in underserved areas, they take they're so scared, right? It's so scary that like all you're concerned about is getting it out. So you're just like, let's just do this. Like whatever option is fine. This guy seems nice. Let's just do this.
Right.
And taking that moment to step back and be like, is this really the best option for me and my lifestyle, my family, or whatever, my risks, understanding your genetic profile, taking that all in, getting a second opinion, really giving yourself that time, because I think that is the one thing that I see in this that I feel, is a disservice to a lot of women in this situation, is that they are rushed. And they're rushed sometimes by themselves out of fear.
Right. And being in the middle of it, it's usually coming from the patient side because of the fear of just having this inside of you. But remember, in almost all cases, breast cancer is a slow growing problem. So a week or two will have no effect, should not have any effect on your outcome. Should not. Now, obviously, there's extreme circumstances, and that's a different story. But in those cases where you can slow roll it a little bit, get your life in order, prepare, and that's a big part of it, because recovery is not easy with breast cancer surgery, and especially with reconstruction. So it takes you a couple weeks to get back on your feet.
Yep.
So that's the last thing I want to talk about before we go. So let's talk about recovery. What are some of the things that people that are listening to this that are going to have reconstruction, specifically with breast implants? What would you tell them about recovery?
I would give them all of the same post-op instructions I'd give a woman who's having breast implants. The limitations on range of motion, thinking about when you can drive again. I usually tell women not to expect to drive for at least a week. Now, if you're having a lot of your lymph nodes removed after surgery, that is something that some women have a lot of discomfort in their arms, or really kind of persistent swelling as their body adjusts to the new lymphatic flow and drainage in that area. So more than anything, just being really patient with yourself and understanding that this is a little bit longer recovery. Even if you feel good, you still do have some physical limitations that you need to be respectful of. You need to allow that incision to heal. You need to follow your doctor's instructions for what you can do physically. And, letting people help you also, I think, is really key. Like,
that's a big thing. I get people to come in about 2 weeks, and, the whirling dervish time has died down, and they're all alone, and they're depressed and sad, and they can't do anything because, especially with implants, you can't raise your elbows above your shoulders.
You're a T-Rex.
You're in a T-Rex or alligator arms. If you're using your own tissue for reconstruction, your limitations are even stronger than that. Definitely about moving around, because you don't want to jerk your body around and affect the area where they connected the blood vessels for your flap. So, you just have to prepare. You have to take the time, surround yourself with family and friends. If you have kids, and many of my patients have kids, young kids too, you got to make appropriate plans for that. And then, as I tell my patients, it's like we're Navy SEALs going to get bin Laden, which is probably That's not even a good comparison
It's
anymore. 'cause
becoming an outdated
I
reference.
know it's outdated, but that we're going in this focused on one task, which is to cure this cancer, reconstruct you, close that door, and move on. If you have the unfortunate if you had the unfortunate news of being diagnosed with breast cancer, just know that there are options, and just know that you will get through it. It's very important to listen to podcasts like this or watch our video so you understand some of the information that you need to understand before doing the surgery, and also to get in your head some of the questions you need to ask.
Yeah, understand your options, I think, is really, really key.
Yeah, and especially on this day, it's very salient
Yes,
that
it
we
is.
did this podcast,
It is.
this episode.
Yeah, so please, if you know anyone out there who might be struggling with this as well, please share our podcast with them. Like us, comment, rate us, review us, all that good stuff. We'd love to hear your feedback or questions you might have on this topic. Dr. Martin really is an expert in this field. He spends quite a bit of his time in practice doing breast reconstruction and is on the sits on the tumor board, so he's very knowledgeable about this. So we'd love to hear your questions. Follow us on Jason Martin MD on YouTube and Instagram, and also at Beauty and the Surgeon podcast.
And rank and rate our podcast too. And honestly, if you're going through this and you're stressed out, listen to some of our other episodes. It might cheer you up
That's
a little
right.
bit.
Our best of is pretty funny.
Yeah, our best stuff is pretty good. It's very light. It's not consequential, so you should enjoy it.
Thanks, everyone.
Thank you.